Our next speaker will delve into the latest insights on polymyalgia rheumatica, focusing on the 2025 updates and essential practices in diagnosis, treatment, and management. We are privileged to welcome Dr. Muhammad Haroon, who is a preeminent rheumatologist. He holds a PhD in rheumatology, fellowship from prestigious institutions, and has published over 50 peer-reviewed articles. His expertise in clinical and genetic research has established him as a leading authority in this field. Please welcome Dr. Muhammad Haroon as he shares his insights on polymyalgia rheumatica.
Assalamu alaikum, everyone. So, thank you very much, as I said, for having me. So, it's a little different today. I'll be talking about is the polymyalgia rheumatica. Right. So, let's dwell into a little bit about the basics in terms of the definition, in terms of the little bit about the etiologies and so on before talking details about the management. So, we know the polymyalgia rheumatica is an inflammatory rheumatic condition. Generally, of course, the neck, shoulders, and the upper pelvic girdle are usually affected in these. Of course, it's an inflammatory condition, so generally you tend to see raised inflammatory markers. So talking about the epidemiology, for example, if you look at, of course, it's more than 50 years of age, around the age of 70 to 80, of course, the incidence is quite a bit. But looking at the figures from the internationally, and I agree with those figures, is that definitely around 100 per 100,000 patients would have one of those features. And naturally, it increases with age. And we know that it's the second most common inflammatory or autoimmune rheumatic condition, second to rheumatoid arthritis. Of course, it goes with GCA a lot of times. For example, in GCA, 50% of the patient would have polymyalgia rheumatica, and other way around 30% of the patient with GCA, with polymyalgia rheumatica, could have concomitant GCA as well. So, talking about the etiology, just like any other autoimmune condition, of course, it's very easy to say it's not well understood. But looking at the familial aggregations, for example, studies, so it's usually is a HLA class 2 driven disease, not HLA class 1. HLA class 1 we generally tend to see in psoriatic arthritis, for example. HLA class 2 we tend to see more the typical of rheumatoid arthritis, and the same is HLA-DR. DR1, B041, that's also very much mimic of what we see, the genetic, for example, the etiopathogenesis in rheumatoid arthritis as well. Naturally, infection and the vaccination have also been attributed towards the etiopathogenesis of this condition. For example, in different outbreaks, there was much higher incidence of polymyalgia rheumatica, has been reported in a lot of European countries. So talking about, of course, the name, the polymyalgia rheumatica, we know it's not myositis, we know it's not arthritis, then what it is. Of course, it implies that might be some form of myopathy or neuropathy or something. But if you look at the imaging studies or even the histological studies, there's no, the muscles are very much preserved. There is no inflammation as such in the muscle as such, but rather we know there is a periarticular structures which are usually affected in this particular condition. And that has been proven with all the imaging studies that you can talk about, for example, ultrasound, CT, MRI, and very, very commonly we see in the PET scan as well. So let's look into a little bit what happens in this particular condition. For example, again, we learn from the imaging studies, naturally, because there isn't much to find on examination apart from the patient complaining about the symptoms. So the subacromial bursitis has been considered as one of the hallmark, one of the most common, rather, finding in the imaging studies in the patient with the polymyalgia rheumatica, and the same goes with the biceps tendonitis. Talking about the neck and the spinal, for example, the symptoms, where do they originate from? Usually it is the interspinous bursitis in this particular condition, which tends to cause these symptoms of this profound stiffness. Talking about, for example, what happens at the hips, it's the same as the greater trochanter areas, the bursitis around those areas, the ischial processes, for example. There is also inflammation happening. For example, the hamstring tendonitis, for example. So these are the usual imaging studies tell us that what happens as regards the pathology and the reason behind these symptoms. Again, talking about the back pain, for example, the usual what we see in the neck as well is the interspinous bursitis is the cause for these symptoms. So in summary, if we want to know where the symptoms are originating from, is the biceps tendonitis or subdeltoid bursitis, the biceps tendonitis and cervical interspinous process, and the same as I just mentioned, what happens in the lower pelvic girdle in these patients. But of course, we need to be mindful. Of course, these are elderly patients. The rheumatoid factors, of course, we tend to request. So the rheumatoid factors in the general population and up to 10% of the older population that can also be positive. So rather than we label blindly to as seropositive rheumatoid arthritis, so we need to be a little mindful. Of course, it would be in the lower titers. And one thing that really helps in this scenario is the anti-CCP antibodies, which is very much specific. In PMR, we do not tend to see anti-CCP antibodies. Of course, rheumatoid factors can be positive, but not anti-CCP antibodies. Distal symptoms can be common up to almost 1/2 of the patient, usually is the rest synovitis, low-grade synovitis, and the MCP synovitis can also be there, and that's concomitant to the usual, the proximal symptom that we tend to see. Of course, it's an inflammatory condition, so we tend to see the ESRs and CRPs raised. For example, if you look at the studies for the ESR, so 94% of the patients would have elevated ESRs, and up to 99% of the patients would have high CRP levels. Rather, it's mentioned that in one study, only 1.5% of the patient would have normal inflammatory markers with the polymyalgia rheumatica. And usually, if you look at the guidelines, for example, if you look at the usual recommendation, people do talk about that the normal inflammatory markers, especially CRP, would practically exclude the diagnosis of polymyalgia rheumatica. I think it's a little bit too much to say. I personally think there's a good bit, at least 20% plus minus, would have normal inflammatory markers or just a borderline. For example, you tend to say 6 or 7, for example, of the CRP. With the right symptoms, that can be enough to diagnose a patient with the polymyalgia rheumatica. We tend to see subclinical vasculitis in the patient with the polymyalgia rheumatica. For example, if you look at the PET scan, the studies have consistently shown that up to 1/3 of the patient with the polymyalgia rheumatica would have subclinical synovitis, and usually these are the subclavian arteries which tend to let up in the PET scanning. If we look at the ultrasound studies, they talk about around 1/4 of the patient would have subclinical synovitis, but that can be involvement of lot of different areas, just like we tend to see in arthritis, the usual like the carotid, subclavian, and the axillary artery, subclinical inflammation on the ultrasound studies. So talking about how do we diagnose? So it's of course, is the age more than 50, early morning stiffness, profound early morning stiffness. There has to be 2 out of those 3 areas, the neck, shoulder, and the pelvic girdle. So if 2 of those areas are affected, age is there, and of course, there is a profound early morning stiffness is there, and naturally the inflammatory markers are raised, and the prompt response to steroids is a very classic that we tend to see. So let's dwell into how to manage these patients. The goals of treatment is very simple. One is to control symptoms, not the inflammatory markers, not the imagings. The most important thing in polymyalgia rheumatica is how to control the symptoms, and of course, to be vigilant about the concomitant vasculitis, and especially worrying is the giant cell arteritis. And naturally, this is the older age group we are talking about, so we need to minimize the risk of the complications of the medication. The steroids has been the cornerstone, even to date now as well, is the gold standard how we treat these patients. And unfortunately, we don't have any class 1 evidence when we talk of how much to use and so on. So it's all, of course, anecdotal evidence of the years and years of experience. That's how we learn that how much steroids we should be using and what the duration would be. Right? So, as I said, the most important thing is how to relieve the symptoms. And to use the minimum amount of steroids for these patients. That has to be the most important understanding in dealing with the patient with the polymyalgia rheumatica. And another thing is, do not always chase the inflammatory markers. Make sure that, of course, there are activity scores for polymyalgia rheumatica. We should be focusing those ones. We should be focusing on their symptoms. And of course, naturally, we should be following their CRP and ESR, but just the borderline in case if the CRP and ESR are still there, but the patient is asymptomatic, you should not be escalating the treatment based on still raised inflammatory markers, especially if they are just a borderline. Initial dose, the mostly is around 15 milligram. That's how we go by. right? But again, there is no like sort of the blanket statement, if you like. That all depends on the patient sitting in front of you, looking at their, naturally the age group. If somebody is like 80, 90 years old, already having diabetes, for example, loads of other complications, but the symptoms are not that severe. Of course, the low dose can be enough. Low dose can be absolutely sufficient. For example, even 10 milligrams can be enough. So again, as I said, it depends on the patient sitting in front of you, looking at the comorbidities, looking at the overall risk and all this, then you can decide 10, 15, or in some patients, of course, with the very high symptomatology, for example, we can easily go up to 20 milligrams. 25 milligrams, of course, we can still use, but if somebody needing more than 25 milligrams of steroids, we should be thinking about some other diagnosis, especially concomitant genital arteritis or some other systemic vasculitis in these patients. Looking at this, a recent systematic review, for example, looking at what should be the initial dose of steroids in treating patients with the polymyalgia rheumatica. There is, as we know, there is so much heterogeneous population used in these observation studies. One was the randomized trial, but there was no conclusion. It was all depends on the patient, as I said, and of course the concomitant other risk factors associated with this. That we should be aiming for what should be the initial dose. Of course, as I mentioned, the response is very, very quick. We tend to see the response. If we are not getting a response within 1 week of starting steroids, doubt the diagnosis, or making sure that if the diagnosis is right, then definitely we need to escalate the dose if the response is not coming within 1 week. Blood test monitoring, of course, the CRP and ESR, of course, is very, very important. Baseline CRP and ESRs are very important, not only for the diagnosis, but also in the follow-up as well, that when the symptoms are improving, of course, the CRP and ESRs are settling or not, and that very, very reassurance when, of course, the patient is sitting in front of you. So the steroid tapering, again, there's no consensus. As I keep on repeating myself, is the symptomatology is the most important, the response is important, not this inflammatory markers in these patients. Of course, how to aim for the aim for the treatment duration is around 1 to 2 years. So thinking about that, we don't have, unfortunately, only 5 milligram tablet available. In Europe, we used to have 1 milligram tablet available. So we used to start was 15 milligram and reduced on 1 milligram a month. So that was like a sort of a standard approach depending on then afterwards. But again, we don't have any such facility. So what we tend to do generally is that we reduce down 2.5 milligram every month until it goes down to 10. And below 10, again, is around 1 milligram a month that you should be aiming for. But as I said, more than 99% of the patients or thereabouts do not go with the same regime because every patient behaves different depending on, of course, the other comorbids. And as I mentioned, usually you aim for 1 to 2 years of treatment plan. But most of the patients would need much longer duration of treatment. And for example, if the two studies that I've quoted there, so the one was that the duration of the treatment was up to 37 months, and the other study mentioned that the patient would need 6 years of treatment, especially in the much lower doses. So how to minimize the risk? First of all, we know that this is the aging population. In two of the studies that I mentioned here, the 65% of the patients with the polymyalgia rheumatica would have some steroid-related adverse event, and the other study showed there was 43% of the patient had some form of steroid-induced sort of complication. However, in an inception cohort, I have mentioned another one as well, the second one, they're talking about the polymyalgia rheumatica with the steroids, that there was just, the cataract was the only one complication which was different compared to the placebo group. But that's, if you look at this one, for example, that was the conclusion of that particular study. But if you look at the details of that particular study, of course, they were looking at diabetes, hypertension, hyperlipidemia, and the osteoporosis-related fracture. But what you and me really see in these patients are what? Weight gain, right? The weight gain. People talk about all the time, that the face is all like puffy. And of course, the other complications related to that. So that's why they did not include in this particular study those complications. And of course, we need to be much more mindful about steroid-induced osteoporosis and all this. So the relapse happens around 50% of the patients with polymyalgia rheumatica. Rather, it's considered that it's more the rule that the relapse would happen than the exception. And usually it happens within the first within a year of the treatment, because of course you're trying to reduce down the steroid dose, so that happens earlier on in the disease rather than the later on. So we tend to see asymptomatic patients with the abnormal testing, as I just earlier on mentioned, that the CRP and ESRs can be borderline raised, but the patient is still asymptomatic. Of course, what I tend to do is I do not follow much the CRP and ESR unless they are broadly, of course, markedly raised and they're not settling. If the CRP and ESR have settled more than 50% and the patient is asymptomatic, I would sit tight and just observe, but of course be mindful of other mimics as well. That can be a problem in some of the patients. So let's talk about the steroid-sparing therapies. So usually it's mentioned that most of the patients, rather you should not be thinking about steroid-sparing therapies in the patient with the polymyalgia rheumatica unless the comorbidities are there, for example, the diabetes, the cardiac risk factors are there, and so on. On those patients, you should be thinking, otherwise you should not. Personally, I do a little different. I tend to, of course, once you have diagnosed a patient with the polymyalgia rheumatica, your thinking really is that this particular patient will be on steroid, on whatever doses of steroids is, and we know the relapses are going to happen, and we know this is an aging patient. So I try, not at the first visit, of course, there's a first visit, you make a diagnosis, you challenge them with the steroids, you want to see the response of all this, you want to see the settling of the ESR and CRP. Once you have made that sort of observation, and then I try to expose all these patients to some form of steroid-sparing agent so that at least some of the steroids can be reduced to at least a decent level earlier on rather than waiting for 2 years and then thinking about introducing these steroid therapies. And we'll talk about what are those therapies. Of course, NSAID, you know, this is aging, of course, again, the population, they're already on antihypertensive, they're already on ACE inhibitors. You don't want to expose them to a lot of NSAIDs in the longer run. The methotrexate, of course, is one of the best friends. We always try methotrexate for any form of joint pains we talk about, so inflammatory joint pains, of course. So looking at the evidence, for example, in polymyalgia rheumatica with methotrexate has been very mixed. We don't have a good evidence as God does it works. And if you look at the old evidence, so there has been a lot of things, one even randomized controlled trial as well, looking at the methotrexate versus placebo. And there always was the issue was the dose of methotrexate used in these patients, because we know these are aging patients. You are worried about the GFR. You don't want to give them a higher dose of methotrexate because, of course, we are aware of the renal clearance. So in all the studies, the low dose of methotrexate was used and it was not effective. However, we have now very recently this double-blind placebo-controlled trial which has been recently published. What they looked at was very, very brave sort of, this study was conducted 52-week placebo-controlled trial, randomized, recently diagnosed polymyalgia rheumatica. Very early on, we are not talking about a refractory disease. We are talking about a very earlier on, right, the patients, and they were blinded and all this, and the primary outcome was by the age of 52 weeks, so let's see, does it help in terms of having a steroid-free remission or not? So 52 weeks, and the very important thing was they went up to 25 milligram of methotrexate. So all the patients, they went up to 25 milligram of methotrexate and 52 weeks randomized double-blind controlled trial, but unfortunately, if you look at compared to the placebo, 68% versus 67%, they did not achieve steroid-free remission. So methotrexate was an absolute failure, not only from the observation studies, but this randomized double-blind placebo-controlled trial, this was an absolute failure, unfortunately. In infliximab, there's only one randomized controlled trial. Again, it wasn't effective. Leflunomide is a very interesting one. I remember talking to Professor Das from UK a number of years ago. I think must be 7, 8 years ago. And he was talking about that time about the leflunomide use in polymyalgia rheumatica. And since then, there have been very good evidence talking about the leflunomide in polymyalgia rheumatica. For example, if you look at this particular observational study, retrospective and also some prospective as well, what they looked at was compared to methotrexate and leflunomide. For example, if you look at the time until steroid discontinuation, so they started both the steroids plus, of course, the leflunomide. The other group was the methotrexate plus the steroid. In the leflunomide group, they were able to stop steroids in 4 to 4.7 months or thereabouts. Compared to methotrexate, for example, if you look at the steroid was stopped after 31 months. right? So compared to methotrexate, leflunomide really did great in this particular study. Right. Let's talk about now IL-6 inhibition. Of course, we know we have the evidence in last number of years. For example, this prospective open-label phase 2 trial, they looked at 52 weeks, again talking about the same, up to four months they kept on using, and the same was in the early PMR, the bottom one, if you look at, that's a very interesting one. What they did was, so the bottom one, efficacy of the first line tocilizumab used in polymyalgia rheumatica in these patients without steroids. So they started on with the tocilizumab without steroids and up to 3 months, 12 weeks, and there was also another 4 weeks observational of the same patient. What they found out was with the tocilizumab, they were able to achieve remission without steroids in polymyalgia rheumatica. There has been few randomized recent controlled trials. For example, the SPARE trial, if you look at these are the new onset of the polymyalgia rheumatica, not exposed to steroids before. So they randomized into 1:1, 16-week study. And again, in this study also, if you look at the graphs, for example, the steroid-free remission was achieved significantly in the patient with the tocilizumab compared to placebo. And the same was that the primary outcome, the probability of the relapse was much, much less in the patients with the tocilizumab compared to the placebo. If you look at another randomized controlled trial, here they were talking about the more refractory cases, the patients who were still having active polymyalgia rheumatica and they needed more than 10 milligrams of steroids and the polymyalgia rheumatica was still active. In these patients, when IL-6, the tocilizumab was used, there was a significant improvement of the up to 24 weeks. The primary endpoints and all those were achieved in these patients. So randomized controlled trial, these two were significant in favor of tocilizumab. And this is a SAPPHIRE trial where, again, the IL-6 inhibitor was used weekly and there was a 14-week steroid drop compared to the placebo where 52 weeks of steroids were given, right? On one arm, 14 weeks of steroid taper was given plus IL-6 inhibition, and the second one, the placebo, there was a 52 weeks of the steroid taper. And if we look at the results, for example, there was a significant remission achieved in the patient with the tocilizumab, with the sarilumab, plus, of course, the overall cumulative, if you look at the steroid use, was significantly less in the patient who used IL-6 inhibitor. Based on this particular randomized control phase 3 trial, FDA approved this sarilumab IL-6 inhibition for the patient with, let's move on quicker. So looking at the rituximab, for example, we have only one evidence. If you look at the rituximab in the patient with the polymyalgia rheumatica, in this particular study, 49 patients were given at the start of the polymyalgia rheumatica diagnosis. They were given one treatment dose, 1,000 milligram, and then again 1,000 milligram, and then they were followed, and significantly higher patients achieved remission with the rituximab, but there's only one report, but there was a significant number, 49 patients, this particular study was used. Baricitinib, which is a JAK inhibitor, very recently published data in the polymyalgia rheumatica. Again, the use was in one their group was baricitinib was used, JAK inhibition without steroids, compared to the other group where the both were used, and significantly the higher number of patients achieved remission with the JAK inhibitor. And talking about the tofacitinib, of course, because which is easily available, this is the Chinese data. And they very nicely did was, they looked at, first of all, looking at the evidence that what is the gene expression analysis in these patients. So in their patients from the peripheral blood mononuclear cells, so this is the CRISPR component analysis. I won't bore you with all this. So PMRA is active PMR, and then this is the PMR in remission, and this is the healthy control. What they looked at was there was a significant difference in the gene expression analysis when they did on these patients. So the inflammatory genes were much more expressed in the patient with the polymyalgia rheumatica compared to the healthy controls. And the genes were all inflammatory genes, and what they saw was that most of those genes, they were blocked, or most of those cytokines were actually blocked by the JAK inhibition. So this is after tofacitinib. So the red ones are the active ones, and the blue ones which have been suppressed after tofacitinib therapy. So those inflammatory genes which were overexpressed after tofacitinib, of course, they all were reduced down after tofacitinib therapy. This is a very recent one published in the Annals of Rheumatic Diseases. They also looked at the 14 patients about the whole different cytokine analysis. Not only they achieved a good response, but looking at the cytokine analysis as well, they were significantly reduced after tofacitinib therapy. So in the interest of time, let's talk about the conclusion. So people, of course, we all talk about that it's a mild enough disease. It's just an inflammatory arthralgia rather than an arthritis. But if you look at the overall significant disease burden it carries, that's a lot. Because again, as I keep on repeating this, we are talking about an aging population which have already got a lot of comorbidities. So it's very important to come up with a plan, not just a steroid, but also looking at some steroid sparing therapies from the start, from the day one. And we need to be mindful about the mimics of the PMR and the vasculitis, which is a very close friend of it. We should not sort of ignore that, especially in the patient who have got persistent inflammatory markers. I have recently seen a polymyalgia rheumatica patient. Again, absolutely surprised me, because one day when the nurse was telling me the blood pressure is not recordable, and turned out to be there was a subclavian stenosis in that particular patient. So these patients do surprise us now and then. Thank you.